Welcome to Heartline, conversations with healthcare changemakers following their heartline. I'm your host, Dr. Andrea Austin. I'm an emergency medicine physician, coach, and educator. I believe that healthcare needs to improve the quality care that patients receive and that supporting the workers is at the heart of this transformation. I am very excited today to have Amy Yackowski, founder and chief evolution officer of Painted Porch with me. Amy, welcome to the podcast.
Thank you, Andrea. It's a pleasure to be here.
Well, you are the quintessential guest for this season of the podcast because we are stepping out and doing new things. I am not just talking with physicians all the time because I feel like we get a little constrained when we're always talking to the same groups of people. So I'm really happy to have you on the podcast. Can you tell us a little bit about your professional background and what you do?
Absolutely. So I've been in the staffing industry, primarily healthcare staffing, for the last 20 years. I've worn a lot of different hats throughout that time, starting first as a call center staffer at a healthcare staffing organization in New Orleans, Louisiana, that helped place nurses across the entire United States 24/7. And then I migrated over to the technology side of the business, helping these staffing organizations really leverage and utilize their technology to the best capabilities that they have, so that way they could most effectively and efficiently help find, connect, and put these very valuable resources, these clinicians, these nurses, and other providers to work, because we know that the United States and the market needs them.
Yeah, absolutely. And maybe we should just start there. You know, I have to say I'm still a practicing emergency physician, and we've lost a lot of nurses. I mean, just to frame it out for our listeners, when I started in emergency medicine as a resident, gosh, I don't know, maybe coming up on 10 years ago, you had to have 2 years of experience before working in the emergency department. And that's not the case anymore. Tell us, where have all the nurses gone and are they coming back?
I think it's a mixed bag, to be completely candid. I think there's a lot of nurses, especially over the last few years. COVID, I don't think, helped the situation at all, but there's a lot of nurses over the last few years who have decided that they want a little bit more autonomy, a little bit more control and direction in the work that they do and how much and where. And so a lot of them have migrated to the staffing world so they can maybe explore new areas through travel nursing and the like. But there's also a very large percentage. I talk to nurses regularly, and there's many of them who have even decided to just leave the bedside entirely. They just have had it. They are worn out, they're burned out, and they are not having a lot of confidence in the future and where things are moving forward and whether or not they are going to, I don't know, feel successful and fulfilled in that care work that they have dedicated their lives to doing up until now.
So on the staffing side, I would imagine, and correct me if I'm wrong, that you work with organizations and you interact with a variety of organizations and see different, shall we say, organizational behaviors, because organizations do have behaviors. They have culture.
Yes.
What are you seeing in this very difficult environment? What healthcare organizations, and obviously don't name names, but what behaviors are you seeing that attract people and that they're leading the pack in retaining and attracting nurses and other healthcare professionals?
I think the big difference, the ones that are doing well and will continue to do well, are those that are viewing clinicians of all shapes and sizes, of all specialties and areas, as resources, not commodities or part of the cost of doing business. I think that that's the real difference. From the staffing side of things, I think the organizations that are really leaning in and giving nurses sight. What I mean by that is, I see you, I hear you, I understand you. It's not just I'm here to place you to meet my head count and my clients, fill ratios. I'm actually seeing you as a fully functioning, valuable resource within the healthcare staffing industry. And rather than just focusing on placements or jobs, actually creating an environment and a community where nurses feel that they can have a voice and they also have resources available to them that maybe aren't being given to them either in the hospital setting, in the clinical setting that they're working in, or with other staffing suppliers that they might have partnered with in the past.
I do have a practical question. The nurses that are coming to staffing companies and doing travel nursing, for physicians, when we do that type of work, we tend to be independent contractors and not employees. What's going on out there for travel nurses? Are they independent contractors or are they employees of a staffing agency, or is it variable?
Yeah, I would say the majority of them are employees of the staffing agency. They're kind of co-employed, I think technically is the term. Many of them are, but different from locums, which is the physician side of contingent work. Most of them are W-2 employees who are employed through the agency.
Fascinating. And I have a hypothesis related to that.
Yeah, go for it.
So I'm an independent contractor right now, and that's the way I wouldn't say most, a lot of physicians work this way. And I think originally maybe it was a good deal, but I'm starting to become a little bit skeptical about how good of a deal it is for me versus how great of a deal it is for some organizations. And this certainly is not tax or legal advice. This is just Andrea's thoughts on the matter. But my understanding is when an organization hires someone as an independent contractor, they don't have to pay payroll taxes on that person. So I feel like as, just the market trends for physician pay, we really haven't seen our pay go up because it's tied to healthcare reimbursement dollars. So our pay is stagnated, and with inflation, which honestly means that we've lost money, we're not making as much money. And there were at some points in the pandemic that nurses were making more than physicians. And they work very, very hard. I would say the student loan debt and the responsibility of medical legal risk, 3 reasons there why a lot of people think physicians maybe should get compensated more. So I guess my long way around to this question is, have nurses kind of figured this out and they understand that under the employee model that they do have some protections, a lot of protections. They get sick time. They have employee protections from being fired without cause, all sorts of benefits that maybe physicians need to start thinking more about.
That's an interesting perspective. I hadn't really thought about it from that angle. Normally, the lens that we look at it through from staffing is that often nurses have a little bit more control over how much they are getting paid when they work in the hospital as an employee or if they work as a contingent worker of some sort. I think there are benefits. I'm probably going to get in trouble when I say this, but I think there are benefits to being a W-2 employee as a nurse with a staffing firm. However, going back to your earlier question, I think that there are many staffing firms out there who, while they are employees, they're not necessarily given the same level of support and guidance as they would if they were, say, an internal employee or an employee of a hospital or health system directly. While they are W-2 and the payroll taxes and the healthcare and the other, elements are provided to them, I worry about it more from a resourcing, from the softer sides of HR, the resources that I don't feel that are as easily or readily available to them that they could take advantage of.
Yeah. I'm going to ask you a really tough question. When things were at the worst during the pandemic, when staffing had really fallen to abysmal levels, which I'm saying that in San Diego. San Diego is a highly coveted place to live and work. And we felt the staffing shortages quite significantly. At some point, it didn't seem like it mattered how much money you threw against the wall. People just were burnt out and tired.
Yeah.
What we noticed is there were a large number of travel nurses working in the emergency department in particular, which is a high risk environment. I can recall that I had a patient discharged with the wrong paperwork in a quite significant way. It was striking, the paperwork they went with, because the only way they went with that paperwork is not looking at all at the person in front of them. And a lot of us had this sense of like travel nursing is destroying the hospital. And there was a lot of hospital people very upset, saying like, we can't compete with the travel contracts. And then there was resentment among the nurses because they inevitably find out, right? They always find out, even no matter how many things are signed that people aren't supposed to talk about their pay. People find out. So what's your take on that?
I love that you asked this because it is something that anytime I'm out there and networking and I tell people what I do or how I serve the industry, I inevitably bump into a couple physicians who say, travel nurses.
Yeah.
They are such a pain in the butt. I don't like having them in my unit or whatever the answer is. And I always have to smirk a little bit with that because, yes, there are always those instances of maybe clinicians who are not quite up to the level or standard of care that you might expect or that you wish to have. And I would say that would be true whether they were an employee or they were a traveler. I think to some extent, there's shared responsibility on both sides of the relationship when it comes to who is placed in any given contract and whose feet are on any given floor, right? I think during the height of COVID, it became it almost flipped to a little bit like manufacturing, like, are they alive? Are they breathing? They can come. Like, we need help. We'll take whoever we can get. But with that, I would say that there is shared responsibility on both sides. As a staffing firm, I encourage them to think beyond the most basic monetary metrics that they use to measure what they consider success within their business or within their organization, to look beyond headcount or gross margin, but to really focus more on quality over quantity. The better quality nurse you have, the greater relationship that you're going to have with those hospitals and health systems over time, you build that trust currency. I would also say on the other side of it, as the hospital, there is a little bit of ownership there when it comes to how you're screening, how you're hiring these individuals, and possibly maybe not shortcutting the amount of orientation that needs to happen for these people. So that way they feel that they are fully equipped. Because at the end of the day, and I think this is a truism that's, that applies across industries, is that most people aren't intentionally trying to do poor work. It's the situation that they're in. It's the education or the guidance that they've been given. They're doing their best with what they know or what they can do in that moment. And so while we can say, it's travel nursing is the problem, I would say it's more a collective. How can we, as both sides of this, how can we as partners in trying to improve and optimize the healthcare industry, how can we come together and make it better instead of it being viewed as vendor versus hospital? Let's actually come together and be more partners in our shared health and success.
Would you say that travel nursing is overall improving nursing and the experience of nurses because of the competition that it's created, that nurses have choice? And if they have an organization that is not compensating them well, that they do not like working for, that they feel that they can move pretty easily?
I am never against healthy competition. So I think I wouldn't say it's collectively making the entire industry better, but I think especially with COVID, I feel that what happened was that there was the giant spotlight that was shown on an area of healthcare or what was happening within healthcare that was otherwise hidden or in the dark for most lay people, right? Nurses know, doctors know, they know what's happening or not happening within the clinical setting. But I think COVID really shone a light to say, oh, wow, yeah, these nurses are, and doctors, both these clinicians are doing a lot. And to some extent, they're not given the recognition, respect, or compensation that maybe they should for the weight of work that they are doing day in and day out.
What's your projections for nursing going forward? Maybe I'll start with my own and then you can agree or disagree. I'm actually really concerned that we're not going to have enough nurses. And I think the two solutions, honestly, are immigration and technology. And what I mean by that is we have people all over the world that want to come to the United States. And there's some countries that historically have had really fantastic nursing programs. And they want to come here and they want to work hard. And they're great nurses. And then the other thought I have is technology, that we have to make the work easier and better. I watch the nurses doing their assessments and the documentation, and we have all these advances for physicians using Dragon mics and other things. And I see how much time the nurses are spending on documentation and how arduous it is, or other physical tasks. So I don't predict that we're going to have enough Americans interested in becoming nurses. I think we're going to have to pivot to some other strategies to staff our hospitals.
Yeah, I'm not going to purport to be a research analyst in the trends of staffing, but I do keep my eyeballs and ears to what people are saying or writing about. And there is a big concern as it continues to move forward. There is a huge population of older nurses and clinicians who are going to be leaving the workforce. And the amount of new grads that are coming out of nursing programs, it's not to the numbers that they need to be in order to, I'm not going to even say sustain, I would say to like critical path to even have like the bare minimum to cover the needs. And I agree. I think immigration is a part of it. There are some staffing firms that I work with directly now whose primary or, one of their key business arms is on international nursing and recruiting and bringing them to the United States. With all of that, though, I think we have to challenge some sacred cows within healthcare. I know that the average time, from what I understand from working with them, the average time from first connection to first placement for an international nurse is somewhere between 2 and 3 years. That's a long time. That's a long time to get someone over here and to get them in the clinical setting. And even then, a lot of them are potentially newer grads. So there is also that ramp up period that needs to happen in order for them to get to the level and the skill level that is expected or demanded from a U.S. healthcare, standard. I think along with that, from a technology standpoint, I don't disagree. I think there are a lot of opportunities. I mean, we can say this candidly, but I do say this anecdotally with a lot of people who aren't in this world, or aren't in the healthcare or aren't in the healthcare staffing realm, that I say, yeah, we're about 10 years behind most other industries when it comes to technology and technology adoption. And a lot of that, I think, is because of some of those sacred cows. I even think from a placement, from a healthcare, from a travel nurse placement perspective, the amount of stuff that they have to complete in order to be considered in compliance is mind-blowing. And you have to think about every time they want to get a new job, whether it's full-time at a facility or whether it's through some sort of contractual, long-term assignment. It's at least like a 3-week process of onboarding and credentialing them. It's minimum like 40 something pieces of documentation, all of these things in order to say, yes, you have met the supposed standards of what we believe you need in order to be successful. I'm not saying shortcut quality. I mean, I said right at the beginning, quality, I think, is the key. But I think you have to be really thoughtful. It's not just adopting new technology, but challenging the protocols, the policies, and the methods to which you are, in fact, trying to gather all of that information and determine whether or not someone has, checked all the boxes to be qualified, whether we're talking about Joint Commission or just from the hospital themselves. Like, what does it mean? And I think a lot of that, if you want especially younger people, you want to get more youth into the industry, you got to make it more simple. You cannot ask them to give up, X number of days or fill out 45 pieces of paper. It's just not going to happen.
Yeah. And so much of that paperwork is redundant. If we have high standards for professional schools, I don't understand why we need to do a hand washing module at every single hospital that we work at. I just don't understand it. And at some point, I truly do believe these modules are making things worse because it encourages checking boxes and just clicking through. And that's not how people learn. So what is it doing? It's just creating red tape and slowing things down. Yeah. And then the other thing too is I worked in the military and I still work in military hospitals. And I think we're not bringing in enough people that can do healthcare related tasks. There's so many tasks that nurses are doing that do not require an RN. Like they don't need to walk patients to the bathroom. It's a very important work. It needs to be done, but they should be working at the top of their license, just like physicians should be working at the top of their license. I mean, we really can't afford to be not using their time effectively. And I think a lot of their time, if you did a time study, like what percentage of tasks really require an RN, it would be shockingly low.
Yeah. I think you hit on something that's really key there, and it's really tapping into the genius and the drive of a nurse or a clinician of any kind. I always say I could never be one of them. I don't have that makeup, but there is a very special type of individual who decides to go into medicine, whether as a nurse, as a doctor. You're doing it for a very particular reason. Not everybody has the same exact reason, but at the end of the day, the reason is to care for and, ensure the health and livelihood of humans, fellow humans. And the more of that we take away from them, the more that we take away from their ability to do those things that were the reason why they got into this industry and got into this profession to begin with. And the more that we have them focus on those administrative paperwork, policy, contingents, all of that stuff, that first and foremost is, to your exact point, not tapping into their innate talents and their drive. But one of the really interesting things is that it also can be one of the key factors of burnout. When we think about burnout, often when people talk about burnout, it's about the amount of work that people are doing. And while I say that is 100% true, especially when it comes to nurses who are on their feet for up to 12 plus hours a day for many days a week, the amount of work is a component, is a factor for burnout, but it's also the type of work that you're doing. Studies have shown more and more, especially over the last few years, that yes, hours put in contribute, but really one of the key things that leads to burnout is when you are not doing work that aligns with what brings you joy and fulfillment. So the more of that administrative work that you do, the more of your energy it is sucking. the more it's depleting you. And so that way, when you are called to do those things that are aligned with your gifts and your genius, you just don't have it in you. You're just like, I'm done. I mean, because you would think about it, logically, we talk about from a non-clinical area, a 4-day work week, 4 10-hour days. That's what we talk about. And we say that's the key to tackling burnout. But if you look at the numbers, most nurse assignments that they're on most are 36 hours a week, 312s. Okay, well, that's less than 40 hours. That's less than 5 days a week. So why are they still burnt out? It's clearly not just the amount of work that they're doing. It's the type of work that they're being asked to do.
Absolutely. Yeah, I've had a theory on that for a long time because I'm in the emergency department. It's a, patient forward environment. I've done 12-hour shifts in the emergency department. I do not like doing 12-hour shifts in the emergency department. Like, I get that it's like 3 12s and then you're done for the week, but it's a lot to ask somebody to be on for that long and to talk with other humans. And honestly, a lot of times humans that are very upset, they're upset that they've been waiting. They're upset because they're ill or injured. And then you tack on like, okay, now you're going to be starting medications that, if you make a medication error, somebody could be hurt or killed. And now we have historical precedents that even if that was a mistake, you could be convicted of murder. That's a lot to ask somebody to handle for 12 hours.
Yeah, absolutely. We talk about the physical labor of the work that they're doing. And I love that you touched on that. Yes, there's the I am on my feet. I am running around like a mad person. I am continually contextual shifting from patient to patient, room to room, moment to moment, sometimes crisis to crisis. There's that piece of it. There's the technical and the practical piece of the work, but there's also that emotional labor. We forget about that. And what you're asking of these nurses, it's not just what they're doing, like, how they're administering a shot or, measuring a blood pressure or whatever it might be. It's not just the physical action that they're doing, but it's also that toll that is being placed on them emotionally. And I don't think there's enough. When I was talking earlier about the resources, I don't think there's enough resources and education and support to help with those pieces of it. We view them as, essential service workers, but at the same time, they're viewed as workers first and foremost. It's a body that's here that's helping execute XYZ, as opposed to all that's being asked of them, mind, body, and spirit.
Absolutely. And there's this term that I've kind of come up with, or concept of, I think a lot of what we saw during the pandemic was this performative appreciation. This appreciation means thank you, right? Like, that's appreciation. Gratitude is appreciation plus an action. And that's, to come full circle to how you began the podcast, is what we're asking for is gratitude. We're asking that our administration sees us. And it's not just a, pizza party for Nurses Week or Doctors Day. It's that the working environment is such that we are seen and heard. And I don't need a perfect work environment. I'm quite familiar with that humans are involved and it's never going to be perfect. But what we do need is that people see us and hear us. And when we have ideas and something happens, that people will at least hear that. I mean, I've worked at places where they don't even want to hear it.
Yes. You touched on really the key here, which is not pizza parties, but appreciation, and appreciation at a level beyond Nurses Week, which is the obligatory time where you might show it, but actually giving them a seat and a voice at the table. And I think that ultimately is why many nurses are either completely leaving the bedside. They're like, you know what? I can get paid probably close to the same amount I'm getting paid here and not be completely exhausted at the end of every shift and every week, and I can find a balance between, presence and purpose. But also, I think that's why there's a lot of nurses that left the full-time hospital setting and decided to pursue something that is a little bit more contingent, because they felt that they could take a little bit more of that control, right, at the end of the day, and not be caught up in the performance, the performative appreciation or recognition that they seem to be getting. And I know that I'll add an aside here. I know there's been a lot of commentary on the rates, the bill rates for nurses, especially during COVID. You even touched on it a little bit earlier and beyond. And while, yes, there were some that were rather high, boosted by COVID incentives and whatnot and reimbursements, I think that it was the opportunity for people to finally go, wait, you're only getting paid how much normally? And going, oh, yeah, you know what? Actually, that's crazy that you're the person, one of the most direct people that are going to ensure that myself, my family member, my friend is healthy and thriving. And yet you're making maybe just a little bit more than, a cable installer.
Yeah, it really goes to what we value, and our actions as a society aligned. I do want to touch on something, this concept of resiliency. And I've been exploring a lot lately that this word has become weaponized against healthcare workers. We've had a lot of, there's just a lot of people saying, suck it up, buttercup. Generations have done it before you. You guys whine too much. I'm an elder millennial. I've heard it. So there is still something to resiliency. Can you paint it out for us using the painted porch as a backdrop for this? Like, what's your definition of that? And how do you talk to people about that in an authentic way?
Yeah, you touched on a lot of the way that resilience can become a term that is used as a Band-Aid, I guess, in a sense, or a pill for a deeper ill. And yes, resilience can often, or even grit, that's another term that sometimes I'm like, I actually hesitate using the word resilience often, but we try to use it in a very specific way. It is not just, to your exact point, like, well, just suck it up and deal with it, just tamp it down and figure it out later. It's like that get to itness, that hustle, that grit, that, fortitude to charge through any impossible task. Really, when we talk about resilience, it's focusing on what is within your complete control. And that's really what we mean by both resilience and mindfulness. There is so much, pretty much everything except you and how you respond and how you process and how you react. Everything beyond that is completely outside of your control. You can't control traffic, the weather, a patient that is having a not so great day. Those are all things that you cannot control, but what you can control is how you choose to process and respond and manage that. I always like to challenge back when it comes to resilience, especially with the coaching and the advisory that we give to our clients. We say, you have a shared responsibility here. And this goes back to something that we talked about earlier in the podcast about how do we solve this for the future? And while it is immigration and bringing additional nurses in, while it is technology and finding ways to simplify what we do, the biggest thing that is going to, I think, change the industry for better or for worse is humanity, is our humanity with one another. And so when it comes to resilience, we can give you all of the breath work, meditation, movement techniques that you can to help kind of stay re-energized and shake off stress. But if you are demanding too much from one another, if you are placing unrealistic burdens on these individuals, no amount of meditation and breath work or resilience, quote unquote, is going to really improve it. There's things that you can do within yourself that can definitely help when those moments, as I like to say, when the shift hits the fan, when those moments happen. But at the end of the day, there is also a responsibility as humans with one another. As the Stoics would say, your cosmopolis, the people that are within your circle, within your realm, within your world, there's a shared responsibility to ensure that we're taking care of each other, not just a one-way transaction.
I am steeped in my research on change makers right now, and I've been making different graphics. And what just came to me as you were saying this, and I love doing podcasting for this, is what resiliency actually is a bridge to your agency.
Mm-hmm.
So sometimes resiliency is leaving.
Yep.
Sometimes resiliency is stepping outside and taking some deep breaths. Sometimes resiliency is walking over to a colleague and saying, I actually don't got this.
Yep.
Those are all resilient behaviors. And we have conflated resiliency with grit. We have conflated resiliency with bottling and stuffing behaviors, and really with detaching from our emotions.
Yeah.
And so I think that's the message I really want to get to people. And when they say, oh, well, the millennials or the Gen Zs are not resilient, I think we're actually pretty effing resilient.
Mm-hmm. Yes. You have a lot that was on your plate even before you knew how to eat, I think. And so, yes, I would agree that there is resilience. It's just looked through different lenses and different definitions of what that means. But I love your definition of it is agency. And yes, it can show up in many different ways, whether you stay, whether you go, whether you take a pause, whether you ask for help, whether you stand up and say, this is not okay. All of those are definitions of resiliency. It's not just grinning and bearing it.
What haven't I asked you that you would love to share with the audience?
Oh, goodness. Well, I think the one thing that I would talk about as we think about what's next for the industry and what do we need to do differently in order to continue to be able to just, I would say, even survive and sustain, like at the bare minimum, right? Because we keep seeing the numbers that keep ticking. I would challenge that with anything when it comes to change is a tricky matter. Everybody says, you always hear, change is hard, but change is the only constant. Change sucks. Change would be easy if it wasn't for people. And it's like, yes, all of those things are true, but also none of them are true. It just really has to do with how we think about and approach change. Like I talked about, I think some of the biggest things when we think about challenging those sacred cows that we have within the industry, and it's not what we believe has to happen, meaning like the check boxes, the compliance, the things like that, like, oh, well, this has to be the way it is. Let's actually take a step back. And one of the primary things that I do within the Painted Porch is organizational effectiveness. And like, okay, let's pretend that none of this is true. Let's pretend if none of these things existed. What is it that is really needed in order to allow us to achieve our stated goals and get to the value outcomes that we're trying to meet? Like, let's pretend that none of these things existed. None of these policies existed. Let's try to pretend like it's day one, right? Like very Jeff Bezos. And with that, it does require, though, a certain amount of discomfort. We have this concept of an immunity to change. And the way our bodies and our minds and our spirits, when it comes to change, when it's presented to us, we have this natural immunity built in to protect us and keep us safe. And so because of that, those assumptions about what must or what is or what has to be can creep in. And one of the first things, the fundamental things that you can do when you want to try to create any type of change, whether it's in your life, in your work, wherever, within an industry, with a mindset, is to really call on the mat that immunity that you have and really assess, is it immunity that's serving me? Is it helping maintain protection? Or is it possibly also attacking the good things as well, that the good ideas that we might want to be creating that can help us make this better down the road?
I have a call to action for our listeners. So I have this theory that we could probably cut half of onboarding, half of annual training with attestations. You've got professionals in your organizations. They know how to wash their hands. Now, it's a different story about why sometimes they don't, but they actually do know. They know how to do all these different things. People know, that harassment's not a good thing. Play by adult rules. These are our policies. These are our procedures. There are PowerPoints available if you'd like to review them. You are going to be held accountable because you're in a professional space, and sign it. That's it. Attest. I have one organization I work with that relies highly on attestations instead of like these arduous PowerPoints. And I love it because it's like nobody learns anything from these PowerPoints to begin with. And two, the whole thing is it's a compliance measure. So attest and move on.
Yeah, I'm all for it. I regularly challenge the things that are stated. I sometimes joke, I'm not trying to steal your baby. Don't worry. I'm just coming at it from a curious lens, pretending that it's not necessary in order for someone to perform their job or in order to, fill that need or that critical gap that you have. I love it. I think attestations, yes, treat people like adults, look at it from a place of opportunity versus risk mitigation. I think sometimes it's trying to find that balance between the two, but we can make it happen if we're willing to have some of the harder conversations that challenge some of those stated norms and sacred cows for sure.
I love it. If we have a listener that is interested in reaching out to Painted Porch, contacting you, maybe working with the staffing organization, how can they get in touch with you?
So you can go to our website, which is on thepaintedporch.com, or you can email me directly, amy@onthepaintedporch.com. We have a variety of services that we offer that are their target specifically for healthcare staffing firms, but also just for individuals who are looking to maybe embark on a new change in their lives and work and trying to maybe equip themselves with some skills so that way they can have that actual resilience, not just grit, but that resilience, that mindset, that confidence, and that curiosity to lean into what's possible and the change that they could make happen.
It's beautiful. Amy, I want to thank you. This has been such a wonderful conversation. And I got into a zone in podcasting that is like the why I do this, because I think we co-created some really important ideas and we came at it from very different perspectives. And that's what I want this season of the podcast to be, is that we're mashing it up. We're going out and talking with people that have a little bit of a different perspective and lens. And I thank you for sharing your wisdom with our audience.
Well, thank you, Andrea, for having me. It's been so much fun.
Thanks for listening to Heartline, conversations with healthcare changemakers following their heartlines. I'd so appreciate it if you could take a quick moment and hit the like button and also the subscribe button that you'll find within your podcast app or platform that you're listening on. It also really helps if you can leave a review. I would certainly appreciate a 5-star review and a few comments about what you liked about this podcast. Don't forget, you can also forward this to people in your network. People love getting new podcasts and changing up what they're listening to. So sending a podcast to a friend or colleague, or even to start a conversation about a change that needs to happen in your organization, is a great way to be a change maker. This podcast represents the views of the host and guests. It does not represent the views of any entity we work for or with. It is also for informational use only and does not replace any professional advice, including medical or psychological. If you are interested in unlocking your true potential, reach out to me. If you're an organization interested in supporting the well-being of your people, I'd love to connect on innovative solutions. Schedule a strategy session at AndreaAustinMD.com. Sound editing services are provided by Better Podcasting Services, and you can find their website at betterpodcastingservices.com. And I'd also like to thank our future Dr. Caitlin Din, who is the production assistant for this podcast.